Okay. Hello everyone. Hope I'm audible and visible. Very good evening. And we've got a new suit here, all done. So the green screen, thanks to Akshay for making this green screen happen. It looks a little bit clear. Fine. So we will continue the same thing what we have been doing for the past 2 days. We did about the ovarian and the breast pathology the first day. We did go to breast lesions in second yesterday and also a little bit of pituitary. So today we are going to go with the rest of it. Good evening, Sakshi. Today we're going to go to the rest of the endocrine organ system. As usual, we'll be starting with a few MCQs from breast pathology. I want you guys to participate in the discussion and do answer. Fine. Before that, as usual, few rituals. So I hope you have enrolled for this. Good evening. And if you're not done, please do it. And I want all of you to be there on Feb 26, 9 a.m. Hopefully that will help your upcoming exam. NEET PG Compact on Feb 19th. If you're free this Saturday, do attend it. And few batches and few courses. These are all free tests for you on the Unacademy app. If you are free and if you need any support in any of the below tests, and there are 2 study with me sessions as well, you can use them, right? And if you're a part of the Plus subscription, you can use this 3-month course just to kickstart your preparation and go in the right streamlined direction. And I hope it's going on well and it will be helpful for you. You can use PathoCups or any code to unlock whatever comes, if whatever course you want to enroll, fine. So on that note, we'll go on to the first today's MCQ. We're going to have 3 MCQs today, mainly in the breast pathology. After that, we'll be going towards endocrine. Might be a short session. Once we finish endocrine, we'll call it off, fine. Okay, I'll mute myself for 15 seconds or 20 seconds. Do answer the question, then we'll start discussing it. Answers? Okay, great. B, all of you went for fibroadenoma, right? Good. A 26-year-old person noticed a lump in the right breast for the past 2 years. There's a mammogram finding here. You can see a tiny bit of lesion here. It's more solid, and grossly also it's a very, very solid lesion. It's palpable, right? And it is also very, very mobile and mobile mass, fine? Great. BIRATs, I'm not the person to discuss. I'm sure you know more about BIRATs than me. My only question is, why can't be option C? It is not an infiltrating rectal carcinoma. It's not a fat necrosis. That too, I can easily rule out. Why can't be fibrocystic changes? That's my question. Can anyone tell me which is not fitting into the fibrocystic change in this question? What is not fitting into fibrocystic change? First thing, fibroadenoma as well as fibrocystic change comes under the benign spectrum. Calcification might be a little bit. Grossly, fibrocystic change are not well-defined lesions like this. They are just an ill-defined vague swelling. Since in a very well-defined lesion, you can see a palpable mass which is freely mobile. You're going to go for a fibroadenoma. And obviously, like you guys said, that it's a very solid lesion. I don't have any areas of cyst, neither in your mammogram nor in your gross imaging. So I'm not, nor in your gross, I'm not going to go for your fibrocystic changes. Fine, great. Okay. So the next image, next question. Again, 30 seconds. Answer the question. Any takers? I thought it was a simple one. I want you to comment. Okay, again, we are having series of answers. You're going for B. We'll read through the question and also we'll look at the image and see what could be the possible answer. It's a 49-year-old person felt a lump in the left breast for 1 week ago. On examination, a firm irregular mass is seen in the outer quadrant of the left side of the breast. Fine. The gross appearance of the excisional biopsy is seen whatever is shown in the image. Fine. So I don't have any other classical history apart from an elderly person having a lump of a very, very short duration. It's an irregular mass. The irregularity of the mass kind of pushes me towards a malignancy, though I'm not sure. right? So when I'm going to look at the gross image here, can I say that this image is definitely not well defined? If I have to draw the borders, it kind of goes like this, right? It's definitely an ill-circumscribed, ill-defined lesion. It's definitely not a well-defined lesion, right? So when it's not a well-defined lesion and an elderly person, more of a firm and irregular mass. Okay, radial scar is also a possibility. Is that a possibility that it could be an infiltrating ductal carcinoma? An elderly person, an irregular mass? Could be possible, right? Could also be a radial scar. I'm not contemplating that, fine. So of the options, both of them are possible, right? Which of the following additional findings are most likely to be present in a physical examination, fine? A blood-tinged nipple discharge can also be seen in infiltrating ductal carcinoma, and axillary lymphadenopathy can also be seen in infiltrating ductal carcinoma. Chest wall tenderness, not likely. Cushingoid phases, not likely the answer, right? So the answer here is going to be axillary lymphadenopathy over than a bloody nipple discharge. Right? Why I'm not going for a bloody nipple discharge and going for an axillary lymphadenopathy is bloody discharge from nipple. If it is really there, will it present as a symptom? It will present as a symptom, right? So the question must have been a 49-year-old present with a mass and also a bloody nipple discharge, right? I'll answer chilpel, right? So this could have been a present and a symptom. Which of the following additional findings is most likely present on a physical examination? When I'm going to examine the patient, bloody nipple discharge is not going to come in, right? It will be most likely present as a symptom, fine. Should have been mentioned in the history, perfect. So the most likely answer for this question, the best of the 4 options here, axillary lymphadenopathy, right? Okay, dental Q, I'll answer your question. Chilpel, I'll answer your question as well. First to chilpel, your question. When you look at this part, maybe I'll use yellow color. All these part, the rest of your breast parenchyma, these are fat. So this could be a normal breast parenchyma on this surrounding. Is the video still blurry? I think for a second there is a drop in internet. I hope it is clear now. Fine. So this outside part, whichever it is, whatever I circled is shaded as yellow in color, those are my normal parenchyma. If you look at the tumor, what has been circled in black color, it's more of firm. It's more like a firm lesion, right? That's a lesion. Surrounding is a normal breast parenchyma. Okay, great. Dental Q, will lymphadenopathy develop in 1 week? Right. So do you think that history is correct? Do you think the patient would have developed cancer also in 1 week? No. The patient has noted it in 1 week, that's all. So any cancer, be it breast or be it cervix, the pathogenesis runs for years together before becoming palpable and before coming to us, fine? So definitely this, though the history is 1 week, the lesion is not present for 1 week, that's all. It could have been for years, right? So definitely lymphadenopathy is still a possibility here, fine? I hope it's clear, okay, great. So let's go to the next question and let's see, I'll mute myself for a few seconds. Do answer the question. Okay, your answers. B, A. Chilpel, do you want to change your answer? B, medullary. D. Okay, there are many of you who have went for medullary. May I know what is the reason most of you went for medullary? If you can comment, that will help me to understand your thought process behind choosing medullary. Okay, we'll read through the question. A 57-year-old has felt a left lump in the left breast, so and so. A 2 cm irregular mass, CT of the brain shows leptomeningeal enlargement. Lumpectomy with axial lymph node was done. Immunohistochemistry shows absence of E cadherin. What is the answer? I'm not going for anything else. The immunohistochemistry shows absence of E cadherin. Answer? If it is absence of E cadherin, we have only one answer. What is that? Lobular, right? So I will not think of anything else apart from lobular if it's an absence of E cadherin, right? So even when it's given, we'll follow it up, and HER2 is also absent, but presence of ER as well as PR. Medullary is ER positive, PR positive, or triple negative? Medullary is most likely triple negative, right? So I'm having a tumor which is ER positive, PR positive, HER2 negative in this case, and it's negative for your E cadherin as well. Fine. Doesn't this look like an Indian file appearance? Though it's not a classical Indian file appearance, does it look like the cells are lined? They are lined, right? Though they are not perfectly lined, it does have some cells one by following one other, right? So it's actually an Indian file pattern that's not so perfectly seen here. It's a lobular carcinoma of breast, right? It's not a medullary carcinoma of breast. There are classical evidences to say it's not a medullary carcinoma of breast. Now, I just put this question for only one thing to discuss, because there has been something going for some time regarding lobular carcinoma of breast. Fine. What do you think is the prognosis of lobular carcinoma of breast? Good or bad? That's one I wanted to discuss. Prognosis of lobular carcinoma of breast, good or bad? The tumor is ER, PR positive. So it's a good prognosis or a poor prognosis? Okay, I would take Shatakshi's answer of both. Good prognosis, early good prognosis, right? See, when prognosis of lobular carcinoma of breast is asked, it's not so easy to determine the prognosis of lobular carcinoma of breast, right? For two reasons. One reason being, like Satakshi said, it's an ER, PR positive tumor. When I'm going to have an ER and PR positive tumor, can I easily give an hormonal therapy and can I try to treat the patient, right? Because of hormonal therapy involved, they do initially have a good prognosis. Okay, this is there for sure, right? But let's assume the patient is having your E cadherin loss. So can I say that the cells are very much dispersed and it can spread to different organs and different structures? Can lobular carcinoma of breast go into the ovary and cause Krukenbergs? They can cause Krukenbergs, right? Like in this question, the CT of her brain shows leptomeningeal enhancement. Could that be metastasis? Will lobular carcinoma of breast go to the brain? Will breast cancer go to the brain? It can, right? So in other words, they can undergo metastasis. When it undergoes metastasis on a later age, the prognosis drops. Okay, the prognosis definitely drops. When we go to management of cancer in real life, leaving MCQ, we don't use the term prognosis. What we use is, we use the term long-term survival or a disease-free survival or a 5-year survival rate. That's what the ideal actual terms used are. The 5-year survival rate for lobular carcinoma is excellent. Because of the hormonal therapy, I can diagnose them, I can treat them, I can kill the tumor cells. But a long-term survival for a lobular carcinoma drops compared to the same state of your infiltrating ductal carcinoma, for the simple reason they can spread and they can undergo metastasis, right? So if something like this is asked, I would prefer the question to be very, very specific. If the question is not specific, I have told you the reality, I'm going to leave it to you to choose the answer. Yes, early they do have a very good prognosis because of the ER-PR positivity, and lately the late prognosis will stop, fine? So this ER-PR positivity and everything is based for your molecular classification of breast, right? We didn't talk about that yesterday. We'll just ask a few questions related to that. I want you guys to answer, fine? The molecular classification of breast, what is it based on? Immunohistochemistry or gene expression profiling? What is the basis of molecular carcinoma of breast? That's the first one. We don't do it based on immunohistochemistry. Molecular carcinoma of breast, the basis of luminal A, luminal B, and your HER2 enrich everything is your gene expression profiling, right? It is not based on your IHC, it's based on your gene expression profiling. What we do read is based on IHC because it's like a cheap alternative. It's based on IHC. In real life, it is not based on IHC, fine? Second question, I'm going to have a patient whose ER is positive, PR is positive, HER2 is negative, Ki67 is 20%. What do you think, which group will this patient fall into? ER positive, PR positive, HER2 negative, Ki 20%. Which group will the patient end in? Luminal A or luminal B? Do comment. The patient will fall into luminal B, right? Perfect. The patient will fall into luminal B, fine. So when ER, PR and HER2 is negative, what determines luminal A or B is your Ki67. When Ki67 is more than 14%, like Yin said, it is going to go to luminal B. Fine. I'll ask you one more question. ER positive, PR positive, HER2 positive, and Ki67 is 7%. Diagnosis. Again, ER, PR positive, HER2 is also positive, Ki67 is 7%. Where it will go into luminal A or luminal B? Luminal A or luminal B? We'll go to Prithvi. This one, luminal A or luminal B? This is a clear-cut luminal B, right? It's also luminal B. I don't care about Ki67 when HER2 becomes positive. When HER2 becomes positive, irrespective of the Ki67, it's going to go to luminal B only, fine. Only when HER2 is negative, it becomes luminal A. Dopamine, can you refresh it once or maybe change the video quality? Is it blurry for everyone? For me, it looks decent. Okay. Prithvi, Claudin type is a subtype after triple negative. Right? For an undergraduate, I would not say to go into Claudin type of breast cancer. It's a subtype of triple negative patients. When the patient is triple negative, we are going to do few other tumor markers so that it helps to differentiate them as Claudin type. Fine. Can you refresh once, Dopamine? Okay. Fine. Those are 3 questions which I wanted to discuss. Okay, thank you. So those are 3 questions I wanted to discuss in the initial half. So now we'll go to images. Images from endocrine. We'll have a quick discussion of it and hopefully we'll learn more new things together. Okay? First image. The organ and the diagnosis. What do you think is the organ and the diagnosis? I want both of them. I'm sure you know the organ. It's a classical case of thyroid. It's a thyroid dissection specimen, and here you have the classical diagnosis as well. You're seeing big structures, big rounded structures. What is that? Hashimoto's thyroiditis, right? It's definitely in case of an Hashimoto's thyroiditis. Can I call it Hashimoto with this image, or should I call it lymphocytic thyroiditis? That's my next question. Yes, this image in Robbins is from Hashimoto's thyroiditis. Can I call it Hashimoto with this image, or should I call it lymphocytic? My report should read lymphocytic thyroiditis only, because Hashimoto is an autoimmune condition. To diagnose an autoimmune condition, I need markers. Without your serology, I will not be able to diagnose an Hashimoto's thyroiditis. I will call it lymphocytic thyroiditis. I'll order for few serological tests. If it is positive, definitely it goes into Hashimoto's thyroiditis. Fine, perfect. So since we are in Hashimoto's, I want you to ask few leading questions in regards with Hashimoto's. Tell me, what is the primary problem in Hashimoto's thyroiditis? Is it type 4 hypersensitivity or type 2 hypersensitivity? Okay, great, Dopamine. Is it type 4 or type 2? That's my first question. Because you must have read about Hashimoto's. Type 4 or type 2? Okay, many of you are going with type 2. Fine. So again, there is a slight thing what you have to learn regarding Hashimoto's thyroiditis. There are 2 diseases which act in the same way. One is Hashimoto's thyroiditis. The other one is your pernicious anemia. Fine. Both of them have the same way of pathogenesis. What happens in Hashimoto's thyroiditis as well as pernicious anemia is, the first thing, the thyroid in Hashimoto gets destroyed due to your CD4 T cells and little bit of CD8 T cells, right? So the T lymphocytes first initially destroy the thyroid. Once thyroid is destroyed, can it create new antigens? Once there's an T cell mediated destruction of the follicle, can it create neoantigens? Yes, I will have neoantigens because it's just being broken, all the cells are being destroyed. Once a neoantigen is formed, can it trigger an antibody production? Let's say an abnormal thyroid peroxidase. Yes, it can. This triggers an antibody production. Fine. This antibody, that's antibodies against your thyroid peroxidase, that destroys the rest of the thyroid, rest of the pathogenesis, right? This is the model for your Hashimoto's thyroiditis. So initially what happens is your type 4. because T cell mediated destruction is type 4. Later on when thyroid peroxidase comes, it's type 2, right? So this is the type of hypersensitivity which happens in Hashimoto's. Initially it's going to be type 4, later on turns to type 2. The same thing happens in pernicious anemia. Which organ gets destroyed in pernicious anemia? I'm sure you know that. Which organ gets destroyed in pernicious anemia? Your parietal cells. So what happens initially in pernicious anemia is same, a T cell mediated destruction of parietal cells. After the parietal cell destruction, either the hydrogen potassium ATPase or just a parietal cell itself causes a neoantigen. Then I'll have an antibody against the hydrogen potassium ATPase or the anti-parietal cell antibody or an intrinsic factor antibody, right? That comes later down the road, type 2, which causes pernicious anemia, right? So two types of hypersensitivity gets involved in both Hashimoto's thyroiditis as well as pernicious anemia. It's totally dependent on the examiner to go with which one. The starting point of both is type 4. The resultant disease is due to type 2, right? Just keep this in mind. Okay. So if I have to ask you, someone talked about loss of self-tolerance, right? So I'll take to dopamine's question of loss of self-tolerance. For Hashimoto's thyroiditis to happen, there are two classical genes which are involved in the predisposition. Can any of you name them? There are multiple of them, but I just want to at least know two. Loss of self-tolerance is one of the important things which triggers this type 4 hypersensitivity. Can any one of you name the genes involved in that? The same genes you can use it for your pernicious and many other autoimmune disorder as well. Have you heard about a gene called as CTLA4? Perfect, Satakshi. Perfect. PTPN22. Great. Perfect. PTPN22 as well as CTLA4, and if you want to add one more, you can add interleukin 2 receptor alpha chain. Fine. Interleukin 2 receptor alpha. These are the three genes which predispose to your Hashimoto's thyroiditis. The same three genes, these are non-HLA genes which predispose to many of the autoimmune disorder. Sorry, dopamine, you gave me a leading question, so I took that and asking few more things. Fine. These are non-HLA. This is involved in your diabetes mellitus type 1. This is involved in your pernicious anemia and quite a few autoimmune disorder which is not dependent on HLA, because whenever it's an autoimmune disorder, the first thing we'll go for is an HLA antigen, right? So these are non-HLA genes which are involved in your pathogens of your autoimmune disorders. Fine. Okay. So regards Hashimoto's, few more questions. We have a pink oncocytic cell in Hashimoto. What is the cell called as? That's the diagnostic cell as well. A pink oncocytic cell, that's very, very classical. We have your Hertel cell. It's a very, very classical cell for Hashimoto's thyroiditis. Second question, can Hashimoto result in a carcinoma? Possible, not possible? Can Hashimoto result in a malignancy? Okay, Soham, CTLA4, yes, that's an antibodies to CTLA4. Immunotherapy for cancers, yes, it is related to Nobel Prize. Hashimoto, yes, it predisposes to cancer. It can cause papillary, it can cause follicular, it can cause lymphoma, it can cause many, many cancers, right? It does predispose to cancer, be it papillary, be it lymphoma, be it follicular. It can cause anything. I'm not going to which is the most common, because there is slight difference of opinion between WHO pathology and surgery. I'm not going into it, but it can predispose to any cancers here, right? Okay, next, lymphocytic thyroiditis. What is granulomatous thyroiditis, right? What is the difference? Difference between a subacute lymphocytic thyroiditis and a granulomatous thyroiditis. Which is painful? Subacute lymphocytic or subacute granulomatous? Subacute granulomatous, the other name is De Quervain, right? Your De Quervain thyroiditis, that's a painful lesion. This is granulomatous. Fine. Do remember this. There have been questions which is basically come based on the painful lesion in thyroid. That's a differential diagnosis on examination. It can be tender, it can be painful. Do remember it. Fine. Yeah, it is painful, right? So one more easier way to remember is you must have read about De Quervain tenosynovitis. That's also a painful lesion. Maybe something coming related to De Quervain is going to be painful. Fine. Okay, I'm going to show you an image. Tell me, what is this? Diagnosis. That's a good one, Prithvi. Diagnosis. it's a spotter, you should diagnose it. Granulomatous, right? What are these? You have seen many things, many cells. That's your giant cell, right? You can see a giant cell. There are lots of nuclei. That's a giant cell. Actually, these are actually epithelioid cells. If you look closely, they are elongated slipper-shaped nuclei. All of them are epithelioid cells. You have a giant cell there. And what do you think this is? This is also a giant cell. Fine. I do have multiple giant cells, and there are lots of elongated epithelioid cells. And you see a follicle which is getting trapped and getting destroyed, right? This is actually a thyroid follicle. So with the giant cell, my diagnosis is going to be granulomatous thyroiditis or a decoherence thyroiditis. Fine. Okay. Subacute granulomatous thyroiditis. Fine. Great. Look at this image alone and tell me what's happening here. I don't want to go to the diagnosis. I just want your comment on this biopsy or this thyroid follicle. Perfect. You're seeing this is scalloped appearance, right? It's not papillary. This appearance here is in scalloped appearance. It's the thyroid, the colloid is being scooped up and is being used for different purpose, right? This is scalloped appearance. Whenever you see scalloped appearance in a thyroid gland, is it active or inactive? It's completely an active thyroid, right? It's a completely active thyroid. So in this image, almost every follicle which is being shown in the image is active. Generally, that doesn't happen. If I take your thyroid or my thyroid, whosoever normal person thyroid is, on a roughly like 10 to 15% of the thyroid follicles are active at one point of time. Fine. Yes, so there's an active follicle. This patient has having a uniformly enlarged goiter, right? So active follicle hyperthyroidism. So most likely Graves, like Swam said, right? So my leading questions are, to call it Graves, are these two enough? Actually, Graves is a triad. The disease is characterized by classical triads. What are the other two findings? One of them is obviously hyperthyroidism with diffuse enlargement of goiter. This is one feature of Graves. I cannot call it Graves with this alone. I need two more things. What are the other two things? I need two more things to call it Graves. Pretibial myxedema is one. That's the second one. You should have ophthalmopathy, right? You should have ophthalmopathy and you should have your pretibial myxedema, dermopathy, whatever it is, fine. So with a hyperthyroidism and an enlarged thyroid goiter, with an ophthalmopathy and with a pretibial myxedema, only then you can call it a Graves disease, fine. Can any of you tell any one antibody which is responsible for Graves disease? The autoantibody. There are many autoantibody. Any autoantibody which is responsible for the pathogens of Graves disease. TSH, we call it long-acting thyroid stimulator, LATS, or a thyroid stimulating immunoglobulin. So these antibodies are going to stimulate the thyroid TSH receptor, and which results in hyperthyroidism. Graves, what type of hypersensitivity it is? Type 1 or type 2, type 3 or type 4? Graves is a classical type 2 hypersensitivity, right? Because I'm having an antibody which is going to go and sit in the Prithvi. I will say not to use type 5 because that has been removed. It's an older thing. So it is, all of them has now come under type 2 only, fine. Type 5 doesn't exist in the recent nomenclature, so I'd say not to use that, fine. If it was there, yeah, it is type 5. Okay. Comment on this image first, then we'll go to the rest. What do you think is happening to this microscopy of the thyroid? Any comments? I'll give you a clue. This is normal. So what do you think is happening? The one on the left is normal. That's a clue. So what do you think is happening to the entire abnormal area? This is abnormal. Colloid is too much. Yeah, that's an easier way to start with, right? So the gross shows cavities. So can I call this colloid too much lesion as an hyperplastic nodule? It's definitely hyperplastic, and you can see that you have a capsule here. So it's a hyperplastic nodule, fine. So hyperplastic nodule is one of the commonest change seen in your multinodular goiter. This is actually multinodular goiter. You can see a nodule here, you can see a nodule here, you can see a nodule here. There are multiple tiny nodules and multinodular goiter. On a microscopy, we'll have enlarged and hypertrophied follicles. Fine. Yeah, it's a colloid goiter. That's all. Pradyuma, blood glucose regulation will come under homeostasis. I don't know your concern about homeostasis. Maybe we'll discuss some time outside the topic today's discussion. Fine. Okay. Great. So if I'm going to do FNAC of this thyroid follicle, what will I get on microscopy? I'm going to do an FNAC on a multinodular goiter. What will you get? There'll be only colloid. Because I won't get anything else. When I'm doing an FNAC, I'm just going to pick up the colloid and there'll be only colloid there, right? So my leading question here is, if you're going to see only colloid and no thyroid follicular cells, can I call it an inadequate FNAC? Because with your INACT question, you must know the adequacy criteria for an FNAC. What is the criteria, adequacy criteria for an FNAC? I'm sure you know the numbers. I should see at least how many follicles and how many cells in each follicles. There's a number for that. I'm sure you know that. It's at least 6 follicles should be present and 10 cells every follicle, right? So that's an adequacy criteria for a normal FNAC. I should see at least 6 follicles and each of the follicles of minimum of 10 cells should be present. So as I said that if I'm going to do an FNAC here in a multinodular goiter, I'm going to see only colloid. So will I call it not adequate or will I still report multinodular goiter? Or can I still report colloid goiter? You can still report colloid goiter, right? I will not call it inadequate. There are a few exceptions for this adequacy. The first exception is when you're seeing only colloid and clinically it's looking like a multinodular goiter. Fine, okay, dental cube. Okay. Second thing, if you're going to see only neutrophils, which means, what does it mean? On an FNAC, I'm seeing only neutrophils. What does it mean? You're seeing only neutrophils on a thyroid FNAC. The diagnosis is simple. I'm dealing with an abscess. When there's an abscess cavity, abscess of thyroid are extremely rare, but when it's an abscess cavity, it is definitely not an qualifying criteria. Third, when you have a classical intranuclear inclusion, which is diagnostic of a papillary carcinoma of thyroid, I don't want this. When you have classical findings of an intranuclear inclusions, that's a classical finding for a papillary carcinoma thyroid, I don't want this adequacy criteria. Fine, that's very, very characteristic. I want you to remember these 3 conditions. I don't want the adequacy criteria to be there to confirm these 3 diagnoses. Fine, this adequacy criteria comes to consideration if I'm not able to diagnose something, then yes, it's definitely required. Ian, I'm going to take your comment here. Orphan Annie eye nuclei, can I see them on a biopsy? Dopamine, I don't teach in academics. I work in a lab. Can we see orphan Annie eye nuclei on a biopsy, on an FNAC? No, you can't. Orphan Annie eye nuclei is a finding seen only on histopathology. It's a finding seen only on HNE. It is not seen on FNAC. Fine. That's the reason I need intranuclear inclusion. It's a formalin artifact. It's seen only on a biopsy and not on an FNAC. Fine. That's why we go for your intranuclear inclusion for an FNAC. Fine. Do remember that. Okay. Great. There are 3 images here. We'll go with one by one. First, this image. Comment on the gross image, whatever comes to your mind. Yeah, biopsy. It's seen in biopsy, yes. Comment on the first image. We'll go with the other 2 soon, but do comment on the first image. Pratima, the orthopedician should be a better person to comment on frozen shoulder than me. Perfect. Can I call it in solitary thyroid nodule? Clinically, this would have precedence in solitary thyroid nodule. Yes. An encapsulated, perfectly encapsulated lesion, that's a solitary thyroid nodule, right? Okay, great. So that solitary thyroid nodule, the lesion on a microscopy is this. What could be the most likely diagnosis? The microscopy of the same solitary thyroid nodule, I'm seeing this finding. Is this normal or not normal? That's my first question. Is this normal or not? That's not normal finding, because normal thyroid will never form an encapsulated lesion. That's my first thing. Second thing, when you look at these follicles, they are very, very tiny, right? They are very, very tiny follicles. These, I'm going to call them, too much pink color is not a problem for me because it's just colloid, right? I'm having very tiny follicles here. That's of concern. When you see very, very tiny follicles, we call them a micro follicles. Micro follicles are a classical finding of a neoplastic lesion. When I say neoplasm, it doesn't mean malignant. It is both benign and malignant together, right? So anything which is microfollicular, I'm going to think of a neoplastic process. Keeping in mind with this, my first diagnosis should be a follicular neoplasm. I don't know what it is. I'm not calling it your carcinoma or your adenoma. It's just in follicular neoplasm, fine? Okay. Let's say that the same thing, this image, the one on the left, then what will be your diagnosis? No, Ian, I'll come to it. The left one, what could be your diagnosis? Most probable diagnosis. Can you describe the cell, whatever you're seeing there? I'll come to answers for. No, Satakshi, it's seen in many conditions. Do these cells look like Hertel cells? Cells with abundant pink cytoplasm? Do they look like Hertel cells? Yes. So answer to your question, Satakshi, this is an Hertel cell variant of follicular adenoma. Fine. So this is an Hertel cell variant. So I can have Hertel cell variant in your follicular adenoma. I can have Hertel cell variant in a follicular carcinoma. Anywhere I can see that. Fine. Okay. I'll answer one by one questions of yours. See, Ian, when it comes to an endocrine organ, I don't comment on a high NC ratio at all. Right? Any endocrine organ in my body is very, very active. Is that correct? When I have a very, very active organ, it will have variation in the size and the shape. That's why if you look at pituitary adenoma, to call it malignancy, I want metastasis. When you take pheochromocytoma, to call it malignancy, I want metastasis. To take in follicular carcinoma, to call it malignant, I need capsular or a vascular invasion. I cannot call an endocrine organ based on ATPR or an high NC ratio as an abnormal condition. Endocrine, normal also, in normal condition also, I can have ATP as well as high NC ratio, fine. So to call it microfollicles, if the follicle in question is at least 1/3 of the normal thyroid follicle, which means you will have this thyroid also in the microscopy, is less than 1/3, I'm going to call it microfollicle, fine. Hertel cell can be seen in many conditions. Radial thyroiditis is not that common, it's a very, very rare condition, fine. Yes, Sagdeep, Hertel cell or oxyphil cell is seen in your Hashimoto's also. Since I'm having a lesion here, Hashimoto will not cause a well-capsulated lesion, so I'm going to call it an Hertel cell variant of follicular adenoma. That's the only reason I'm going for follicular adenoma, fine. Okay, I hope I answered all the questions. Okay. Diagnosis, comment on one by one. First image. The first image, it's a gross lesion. I don't see an exact capsule here. Definitely there are lots of papillary projections, right? Even in the gross, I'm able to see the papillary projections, right? Multiple outgrowths looking like a papillary thyroid lesion, right? Microscopy, the first image, am I right in saying that the image, the B whatever is masked, is also papillae? It's definitely a papillae, right? So the papillae, but a cut surface of the papillae, that's what I'm seeing here. All these are actually papillae, but the cut surface of the papillae, fine. What you're seeing in the third image? The third image shows, that's the one which actually shows whatever we want to discuss. It shows the intranuclear clearing. That's your orphan Annie I nuclei. I'm having crowding of cells and I'm having clear nuclei. This is an orphan Annie I nuclei. Fine. Okay. Great. So I'm going to go to the next image. The next image here is FNAC, right? So in FNAC, I told you intranuclear inclusions are diagnostic on an FNAC, not an orphan nuclei. Where are you seeing intranuclear inclusions in this image? Can any of you point out? Let's assume this is 12 o'clock, this is 3 o'clock, this is 6 o'clock, this is 9 o'clock, clockwise. Tell me which clock position you are seeing intranuclear inclusion. I just want you to pick it up. I hope you will pick it up. Nuclear. Yes, intranuclear pseudo inclusions. Where do you see them? Great. Can I call this an intranuclear inclusion? Yes. I have circled one. You can see a clearing inside the nucleus. That is your intranuclear inclusion. Fine. This not so much so, but yes, Rohan. But yes, one on the top definitely is an intranuclear inclusion. This also should be an intranuclear inclusion, but I'm not able to exactly differentiate. But the one on the 1 o'clock to 2 o'clock is definitely an intranuclear inclusion. Fine. So that's what I will see in FNAC. I won't see anything else. Intranuclear inclusion, diagnostic of it. Fine. Okay. So let's try and discuss something about few variants of papillary carcinoma thyroid, because papillary carcinoma thyroid we have been discussing many times. We have not discussed the variants much. Fine. Let's say that there's a variant called a tall cell variant. So tall cell variant of papillary carcinoma thyroid, there are few unique findings of this. Tell me one common mutation which is seen here. Any mutation which you know in tall cell variant? There's one classical mutation which is seen almost in every case of tall cell variant, which is BRAF. It's tall cell variant of papillary carcinoma thyroid. BRAF mutation is seen in 100% of the patient. That's the first question, right? Tall cell variant as opposed to a normal classical papillary carcinoma thyroid, they have more incidence of metastasis or less incidence of metastasis? Just regarding tall cell variant, they have more chance of mets, more chance of invasion compared to your classical papillary carcinoma thyroid, right? So which means obviously they don't have a good prognosis. The second variant is a diffuse sclerosing variant. There are 13-14 variants of papillary carcinoma thyroid. ROBBINS have mentioned 2 to 3 of them. I'll just discuss about them alone. Fine. A diffuse sclerosing variant. There are a few unique things. The age group of diffuse sclerosing variant is children. They're generally seen in younger individuals, maybe in children or 20-30 years. They're not seen in elderly. That's one classical thing. Diffuse sclerosing variant, as the name says, it has lots of sclerosis, which means it has lots of desmoplasia. So do you think it will have a better prognosis or a very bad prognosis? Diffuse sclerosing variant have a very poor prognosis. It's a very extremely aggressive cancer. Almost every case will have metastasis at diagnosis. Third thing, diffuse sclerosing variant are BRAF negative. Actually, they are positive for one more thing, one more mutation. Can anyone name the translocation seen in papillary carcinoma thyroid? I hope you must have read them. They are BRAF negative, so I don't have a targeted therapy also. They are positive for one translocation, RET and PTC translocation. It's not RET mutation, it's RET and PTC translocation, which is very common in diffuse sclerosing variant. 1/2 of them will have it, fine. Which thyroid carcinoma will have RET mutations? This one thyroid carcinoma will have RET mutations. Medullary carcinoma thyroid, right? It's RET PTC translocation and RET mutations will be seen in medullary carcinoma thyroid. Okay. Yes. Perfect. Fine. There's one more variant called as a follicular variant of papillary carcinoma thyroid, which means it's the same orphan nuclei, but it will be in the form of follicle. That's a follicular variant. Prognosis wise, there's not much of an alteration. Still, we are in contemplation whether it's a separate entity or a follicular carcinoma. Fine. Okay. Look at this. Can I call these microfollicles? Soham? It's very dense, and all of them are very tiny, right? So the one in the A image are definitely microfollicles, very tiny follicles, right? Next, what is demonstrated in this image? The one in the below B image. What is demonstrated in the B image? It's a classical finding which is required to call it a cancer. It's thyroid, right? A capsular invasion. Perfect. Can you see the capsule here? Can you see the capsule here? So what I have drawn in the blue one is a perfect capsule, and what's happening is the tumor is gone, encroached, and going into through the capsule outside, right? That's a perfect capsular invasion. Capsular invasion is must to call it an invasive follicular carcinoma of thyroid. Without capsular or a vascular invasion, I cannot call it a follicular carcinoma of thyroid. Right? Again, to compare, to call something as microfollicle, every thyroid will have normal. The surrounding is a normal follicle. I am going to compare that, and when I compare this to that follicle, definitely it's less than 1/3. I can call it a microfollicle. Fine. There's definitely invasion. Okay. There's nothing but retained colloids in few of the follicles just to complete it. Okay, that's how you diagnose a follicular carcinoma of thyroid. A famous MCQ. It will not end. Thyroid will not end without asking that. Can I diagnose follicular carcinoma of thyroid on an FNAC? I'm sure you know the answer. Follicular carcinoma of thyroid can never be diagnosed on an FNAC. It can be diagnosed only on a biopsy, right? Right, great. Okay, we have 3 images here. Ignore the gross image, just a mass lesion with lots of hemorrhage and solid appearing mass. Fine. So tell me what you're seeing in this image, the one below the gross image. What are you seeing there? You made me much old dopamine. I love to be a student of pathology. It's pink, it's amyloid, right? It's definitely amyloid, right? So when I see amyloid in a thyroid cancer, what do you call of, right? It is obviously only one thing can have amyloid in thyroid carcinoma, which is medullary carcinoma of thyroid, right? So can I say a patient with a medullary carcinoma of thyroid will have secretions, will secrete calcitonin, because they come from a parafollicular C cells of thyroid, so definitely they will secrete calcitonin, right? So if it secretes calcitonin on an electron microscopy, can I see neurosecretory granules? Can we see them? Definitely we'll see them, right? So medullary carcinoma of thyroid will also have these neurosecretory granules. Now multiple neurosecretory granules seen here. That's a classical finding in medullary carcinoma of thyroid. If you remember, we yesterday saw neurosecretory granules also in your prolactinoma. That was also secreting. Anything which secretes on a microscopy will have something resembling a neurosecretory granules. Do remember them. Any tumor which secretes will have the same finding, neurosecretory granules like this. Fine. So let's take that. When I take medullary carcinoma of thyroid, it's a possibility it can be both syndromic and sporadic, right? There's definitely a possibility it can be both syndromic and sporadic. Which of these two do you think is more common, syndromic or sporadic? Definitely sporadic is much more common than syndromic, right? So when I'm going to say syndrome, there must be few subtle clues to call it a syndrome. Fine. Both men 2A and men 2B can have medullary carcinoma thyroid. If I'm not giving you a history that age group is 10 or 15 years, I'm going to give you only microscopy. What pointer will tell you it is syndromic and not sporadic? I'm going to give you only microscopy. I'm not going to give a history of 5 years or 10 years old. What microscopic finding will help you call it syndromic and not sporadic? Thank you, Dr. Mine. Okay, I'll rephrase this question. I want you to answer. If it is a syndromic carcinoma, MEN2 syndrome associated medullary carcinoma of thyroid, can I say that every parafollicular C cell in that thyroid will be predisposed for proliferation? Yes or no? Because the syndrome starting from zygote formation, yes? More than multicentricity, I'll take Dr. Chilpul's answer. There will be associated C cell hyperplasia even in the normal thyroid parenchyma. When I take a normal thyroid parenchyma which is non-neoplastic, there will be lots of C cell hyperplasia. This tells me it is not a sporadic one, it is definitely syndromic. Yes, this might in future give rise to cancer, which might become multicentric. Fine. C cell hyperplasia, if you see in a normal thyroid, it's going to be suggest too often. syndromic cancer more than a sporadic cancer. Fine, that's a finding. Just I want you to know. I'm sure you know much about the inheritance and everything. Fine. The gene mutated in MEN syndrome is MEN2 is. What is the gene mutated in MEN2 syndrome? RET, right? RET is a proto-oncogene or a tumor suppressor gene? I just want to extrapolate the concepts of neoplasia to a surgical management. Listen carefully. RET is a proto-oncogene, right? RET is a proto-oncogene. When it's a proto-oncogene, like Ian said, it will be a gain of function mutation. Fine, great. Listen carefully and answer. If it is a gain of function mutation of a proto-oncogene, how many alleles or copy mutation will result in a cancer? One allele or two alleles? Or in other words, will proto-oncogene follow Knutson's two-hit hypothesis? One allele should be enough, right? So one allele mutation is more than enough for me to cause a cancer in case of a proto-oncogene. Yes, I have two alleles. One of them having gain of function, more function, so that is enough to cause a mutation. That is enough to cause a cancer, right? Perfect. We'll keep this, right? So when I say MEN2 syndrome, can I say that this allele is mutated in utero? Because during zygote formation itself, it is mutated. Yes, sir. The tumor suppressor gene follows Knutson's, right? Can I say this mutation has happened in utero itself? Yes, correct. So in utero itself, this patient is risk of having a cancer. Yes, which means when do you do prophylactic surgeries? Can I wait for 10-20 years, or I have to do it at 1 year and 2 years? I should always do the surgeries very, very, very early, right? If you remember your medullary carcinoma thyroid syndromic management in your surgery, you must have read for few mutations, the thyroid should be removed at 1 year and 2 years of age. Since it's a proto-oncogene, inheritance of proto-oncogenes are extremely rare. The only mutation is red proto-oncogene. Rest everything is tumor suppressor gene, right? So we have to plan a very early surgery if I diagnose it, because even if I leave it for few years, 5 years, 6 years, if it is syndromic, it will become a cancer. Once it becomes a cancer, it becomes very, very difficult to treat the patient, right? 5 years for MEN2A, I think 1 or 2 years for MEN2B, right? It's a very, very early diagnosis, because very, very early management, because a proto-oncogene, only one allele is enough to cause a cancer, fine? Okay, I'll ignore this. Comment on this image. Tell me what you're finding in this image. What organ is this? That's enough for me. Is it thyroid? Is it parathyroid? What organ is this? Hey, comment on the organ. I'm not going to ask you the diagnosis. Just comment on the organ. We'll come to the diagnosis soon. Perfect. Bony trabecle, right? So then bone biopsy, bone or your bone marrow. Now, do you accept, all of you accept there's a bony trabecle? Yes, that's definitely a bony trabecle, right? So it's a bony trabecle. What are these? What are these? What are these? Though it's a low power image, can I call them multinucleated giant cells? I'll give you options, Ajay, soon. That's a bony trabecle. You have fat here. That's a bone marrow space, right? So all of them here are multinucleated cells, right? So it's an osteoclast. Great. Fine. So when there's too much of osteoclast in a single image, can I say that they will cause more bone resorption? Obviously, right? So which hormone is responsible for bone resorption? Yes, it's a physiological giant cell. Which hormone is responsible for bone resorption? PTH, right? So can I say in this patient there is more PTH, so I am having more osteoclast which is resorbing the more bone? Yes. So when there is more osteoclast causing bone resorption a lot, I'm functioning more. So can I have more vascularity? This obviously will increase the vascularity. When vascularity is increased, can I say that lesion will be more hemorrhagic or more brown in color? So this is nothing but a brown tumor, right? So there's a brown tumor seen in case of an hyperparathyroidism. Brown tumor is seen in the bone because of the more vascularity, more function, it's destroying more, so it forms an hemorrhagic mass, which is called as a brown tumor. Fine. So if I have to link a bone with an endocrine organ, the one area where I can link is your hyperparathyroidism. Fine. Let's look at hyperparathyroidism. You must have heard that mnemonic, right? Abdomen pain, psychic moans, abdomen groans, renal stones for hyperparathyroidism. You must have heard it. Bone pains. At least some of you must have heard the mnemonic, right? Let's try and give life to the mnemonic. Mnemonic is a bit irritating because I cannot create a new mnemonic, right? So when I say hyperparathyroidism, it's going to cause increase in the serum calcium, right? When there's going to be an increase in serum calcium in a patient, obviously the calcium in the entire body will increase, and wherever I have tiny capillaries, calcium is a salt. Calcium goes and gets deposited. When calcium goes and gets deposited in the renal tubules, can it cause a kidney stone? It will cause a kidney stone, right? That's why we have the first component. I can have a kidney stone, right? Second, when the same thing, because of hyperparathyroidism, my osteoclasts are going to resorb the bone. It's going to make the trabeculae very, very thin, and it causes your bone pain. Fine. Third, it's calcium. When I think about calcium, when do you think calcium will get deposited? During when it's a salt, or when it's Ca2 plus, or calcium phosphate, or calcium carbonate? When do you think it will get deposited? It will get deposited in your salt form, right? The calcium carbonate and the calcium phosphate will get more deposited compared to pure elemental calcium, fine? So this calcium carbonate and the calcium phosphate will get deposited when there's a very, very drastic pH change, fine? When there's a very drastic pH change, happens in your intestine. Stomach to intestine, when it moves, the drastic pH change, it gets deposited, right? So once the drastic pH change get deposited, in this GIT, I'm going to have extra calcification. I'm having calcification in the GIT during peristalsis. Can this calcification cause pain? Can it cause pain? It will definitely cause pain, right? So that's one of the reasons for your abdomen groans. The abdomen groans are actually due to the movement of the intestine interspersed with your metastatic calcification. Yes, like Ajay said, that it can cause pancreatitis as well. Pancreatitis is more of an acute condition that also can result in abdomen pain. This is an unnoticed long-standing abdomen pain because of this. Next is your psychic moans. Psychic moans, I'm sure a physiologist will be able to better explain it than me. But calcium is an important neurotransmitter. When I'm going to have hypercalcemia, definitely it will cause disturbances in the neurotransmission. It will cause your psychic moans, fine? All of them are due to hypercalcemia. So can I say all these areas I will have dystrophic calcification or metastatic calcification? In all the areas, dystrophic or metastatic? It's more serum calcium, so we'll have metastatic calcification, right? So all the areas will have metastatic calcification. It's more serum calcium. All of them started with increase in serum calcium, metastatic calcification, not dystrophic calcification, right? It's metastatic. It's metastatic. Don't forget it. You shouldn't forget it. Meta means change. More serum calcium is change in homeostasis, change in the serum calcium, which is metastatic calcification, fine? Okay. Dystrophy means, dys means abnormal. Destruction is abnormal cell. When there's a degenerated tissue or a destroyed tissue, you'll have dystrophic calcification. Here it is serum calcium being abnormal, so change in serum calcium homeostasis, metastatic calcification, fine? Ajay, hopefully you will not forget it again. Okay, we'll just end with this image. I wanted to discuss this image only because of the electron microscopy. Fine. So this actually in pancreas microscopy. On the top you can see beta cells, alpha cells and your delta cells secreting insulin, glucagon and stomatostatin. Actually the below 3-1 are electron microscopy of same beta cells, alpha cells and stomatostatin secreting cells, right? They do have a different appearance, though all of them are from pancreas. They do a slightly different appearance in the electron microscopy. If you look at the first one, beta cells, right? You have a membrane, surrounding that you have a very clear halo. I'll just zoom this alone. You have a membrane bound vesicle. These are same secretory granules. Surrounding that you'll have a clear halo. When you have a halo surrounding them, this is how beta cells of pancreas looks, which secretes insulin. Fine. The next image, if you see, that's these. Can you see there is a center dark zone and a surrounding light area? I'll come to it. So a center dark zone and surrounding light area. Yes, that's how an alpha cells looks on an electron microscopy. Fine, you have a central dark zone and then you have a surrounding paler area. But when you look at the delta cells which secretes stomatostatin, I don't have any variation. It's a uniform thing. Fine. This is how one delta cells appears on an electron microscopy. Fine. So you have 3 different cells of pancreas. The alpha cells, your beta cells will have a neurosecretory granule surrounded by a clear zone. Alpha cells will have a central dark area surrounded by light area. Delta cells will be uniformly same color, right? So these are 3 electron microscopy difference of pancreas, endocrine part of pancreas. Okay. So if anything comes, if they want to ask, because electron microscopy is a very useless thing diagnosis wise, but unfortunately INICD wants to push electron microscopy to you guys. If it comes, hopefully it will help you, right? So I hope rest of your friends have answered the reason. We will see more about the interaction when we discuss about bone lesions. Fine. Okay, try to stop it here. I'll go with rest of little bit of endocrine and maybe skin and bone and joints in the tomorrow's class. Fine. If you have any doubts, do let me know. If there are no doubts, we'll call it a day. Any doubts? Thank you, Chilpal. Which one you want, Ajay? Little bit more in the sense. Two more images. We'll definitely do it, Ajay. We definitely have lots of time. I hope you are giving the upcoming NEET exam. We have lots of time. We'll definitely discuss more. Fine. Thank you for your time. I'll see. I have to go back to sleep, right? Definitely will do. Okay. See you. Bye bye. Thank you. Good night. Nikhil, the videos will be available only on Unacademy. Apart from that, there'll be nowhere else. Fine. I'll share the PDF, Shiva. I'll do it.